Hello, this is Scott Hoye.
And I'm Kyle Miller. Today's episode of the Psychology Talk podcast is from the vaults. We've handpicked some of our favorite and most popular episodes to share with more listeners.
Since we started this podcast, we've been on a mission to better inform clinicians and consumers on topics in mental health. We strive to reduce myths and misconceptions and enlighten you beyond the many memes or sound bites that try to sell you on ways to better your life.
So without further ado, here's an episode from the archives to do just that. So please do your part and take a moment to subscribe, like, and leave a review for us at Apple Podcasts, Spreaker, or wherever you're listening in from. That would help us to continue our mission at the Psychology Talk podcast.
Welcome to the Psychology Talk podcast. We are your hosts, Dr. Scott Hoye, clinical psychologist,
and Kyle Miller, licensed counselor. Psychology Talk is a unique conversation about psychology around the globe. We speak with psychology experts to keep you informed about current issues and trends. We advocate toward reducing stigma and educate about mental health.
While you're listening, please take a moment to give us a review and subscribe on Apple Podcasts, Spreaker, or your favorite streaming service. It helps us to continue providing you with quality programming. And now, enjoy the episode. Hello, everybody. This is Dr. Scott Hoye. Today, my guest is Kelly Mahler. She's a pediatric occupational therapist in the central Pennsylvania region. She specializes in the development of self-regulation and social cognition skills. Kelly's the winner of multiple awards, including the 2020 American Occupational Therapy Association Emerging Innovative Practice Award and a Mom's Gold Choice Award. She is adjunct faculty at the Department of Occupational Therapy in Elizabethtown College in Elizabethtown, Pennsylvania. She's the author of several books, including Sensory Issues and High-Functioning Autism Spectrum and Related Disorders, the Interoception Curriculum, and the Interoception Workbook. She's here today to discuss the concept and function of interoception and how it manifests in our lives in physical and mental health and dysfunction. Kelly, we're honored to have you here. Welcome to the show.
Well, thanks for having me. It's an honor to be here.
Well, thank you. Well, maybe what you could do is first off kind of introduce the idea of interoception, what it is, how it manifests in our life, why it's important both for physical and mental health. And I'm bringing this up because I've come across this concept working in my practice with people who have problems with alexithymia, or the ability to name emotions, and the ability to kind of know what their physical sensations might be over time. But if you can kind of bring this out, I think it's important. I think it's a growing area in neuroscience research and psychology, obviously occupational therapy and other areas of medicine. So please just, I'm going to leave the floor open to you because you are the expert in this.
Well, thank you. Interoception is a really big deal in all of our lives, and it's something that, as you mentioned, is now just starting to emerge. It's been widely studied in areas like psychology and occupational therapy and neuroscience and medicine, but it's now just starting to infiltrate into the general population. And what interoception is, it's a sensory system or a sense within our bodies, and it just works just like our other senses, like sight and sound and touch and taste, and it's pulling in sensory information, and the information that interoception is responsible for is pulling in information from the inside of your body, specifically how the inside of your body is feeling. So interoception allows us to feel sensations like our racing heart or tense muscles or a growling stomach, and it's because this sense has a set of like little receptors in charge of pulling in that sensory information from all of these different areas on the inside of your body. And so being able to notice your bodily sensations like a racing heart or tense muscles or a growling stomach, they all provide really important clues to our emotions and what emotion we're experiencing. And so answering your question about the whole mental health connection, I mean, we need to be clearly aware of how we're feeling in order to manage it effectively and to like really promote those, that positive mental health. And so if we're really connected with the way that our bodies are feeling, what research tells us is we're better able to manage and regulate our emotions, which of course is the foundation of positive mental health.
Absolutely. Yeah. Well, how does this manifest in autism spectrum disorder per se? So maybe we can kind of distinguish that, because I think that's where most of the research has been done with this. Correct me if I'm wrong. Certainly, a lot of the research you've been doing and the clinical work you've been doing. And how does it? Maybe we can differentiate between that and how it manifests in what we would call the rest of the population outside of maybe people with those diagnoses.
Yeah, that's a great question. And interoception has, in the past few years, been studied in the autism field. And a lot of the research is finding that for many autistic individuals, they do have interoception challenges. Some of them can be like they are under-responsive to their internal sensations. So they completely miss that growling feeling stomach or that racing heart. So they're missing those valuable clues to let them know, like, hey, I'm hungry. I need to seek out food. Or I might be anxious. I need to use like a coping strategy. Or on the other hand, they can be over responsive to their internal sensations. So they feel so many different things happening on the inside of their body at once. They can't make sense of it. Like it's not providing a really solid clue as to exactly how they're feeling and how to proceed. So there's two different categories there of difficulties that autistic people can experience. Now, not all autistic people in these studies have interoception challenges, but a high degree do. And that percentage is variable across the studies that you're looking at. The highest number I've seen is 74%. So it's something that we do need to be aware of if we're supporting individuals that have autism. But I think what is really interesting is that interoception challenges impact so many other conditions. And there's been some white papers written in the last 2 years. One that I found to be extremely profound, and that interoception challenges have been found to be a pervasive part of every single mental health diagnosis there is. So that includes anxiety disorders, depression, trauma history, like so many. This is like such a big deal that we all need to really be paying attention. And I think what I would like to see is more practical application. Like, what can we do? What we're missing in the interoception literature is, yes, these interoception challenges exist, but what is the best way to support the interoception needs in our clients, regardless of their diagnosis or condition?
Yeah, wow. I mean, that white paper you're discussing of like all mental health issues have interoception plays some kind of a role in health and dysfunction. How specifically does it do that? How might that manifest in anxiety or PTSD or depression?
Yeah, so that's what I would say researchers are still debating about exactly what that role is and how does it influence. There's some studies that say that individuals that have anxiety disorders have that over-responsive inner experience, where then there's other studies that say individuals with anxiety have that under-responsive experience. So there's not a general consensus yet of exactly what it looks like in each individual person and exactly how do we proceed in supporting it. But they know that these interoception challenges are present. So I would say the interoception field is in itself in its infancy, and it's like exciting to me because I think the mental health field, we got so cognitive for so long, we forgot about the body, and now we're like swinging back into there is this whole body that we also need to include in the supports that we provide.
Books and information like The Body Keeps the Score and Polyvagal Theory that has come along now. More of an emphasis on mind-body, a swing back to mind-body techniques like hypnosis or mindfulness, things like that. Yeah, absolutely. And interoception is providing the science as to why that's so important, and why we need to be connecting the body with the mind. Well, let's say you're working with someone who you suspect has, or I know that you created some assessment tools for interoception, correct? And
yes.
Which is kind of exciting for me because as a psychologist, I like those kind of things. But if you're assessing this, if someone's having a difficulty knowing how they're feeling, either physiological emotions or affective emotions, it's kind of like they're like, "What do you mean?" Right? So they're in the dark about what you might be saying to them. So how do you introduce interventions and assessment to somebody, let's say somebody with ASD, or maybe they don't have it. Maybe they just have interoception problems, standalone. Or
right.
something. It's possible, right? How do you introduce those assessments and interventions so that you're able to provide that insight? Like, what's it look like? How do you connect the dots for them? How do you help them connect the dots between physical and affect and understanding of self?
Yeah, that's a great question. And I'm all about nurturing curiosity. So curiosity in myself as a practitioner and helping and being really curious about what is their individual experience with their body sensations, but then also setting up a process where they become curious and learn about their own interoception experience, and then helping them to grow in that path. So like pretty much like a coaching model. And I mean, we have obviously systematic ways of doing that, like the interoception curriculum, but it really is all about, it's not like this notion of like, we're going to fix you. It's just nurturing this curiosity process.
Yeah.
And I'm a huge fan, and I'm always teaching my grad students, like, we need to be better at asking questions and like figuring out the right questions to ask to help understand someone's unique experience so that we can meet them where they're at and guide them to, wherever they want to go.
Yeah. Okay. So that's basically like the tool of doing that. It sounds like. Right? How might it look like in a specific case? I know that you mentioned in a webinar I attended online the case of a person with not understanding what was going on if he was full.
Right.
Right.
Well, I would start out like by asking questions. I mean, if you're working with a client that has the cognitive or language ability to be able to answer questions, like one of the assessments we have is just an interview, and it's really just kind of a qualitative. It's not a standardized assessment. It's just a guide of like I said, being curious, digging deep, figuring out someone's experience. So we would be asking questions like, well, how does your body feel when you're hungry? How does your body feel when you're full? How does your body feel when you're tired? How does your body feel when you're frustrated? And you really like start to get some insight. I've been doing this assessment for probably over 8 years. I think it was published. And the questions and the answers that I hear still surprise me from some of my clients. Just their answers are so enlightening. And for so long in my practice, I was assuming that people knew how they felt and that they even understood words like frustration or anxiety. And those words can be very abstract to someone that have interoception challenges. So this process and learning about interoception has really shed light and helped me to understand my clients so much more. So we just start out by asking the questions and then figuring out, okay, like where do we need to start?
Okay. Well, I think this might be a good way to kind of segue here. How did you come across this fascinating subject of interoception, right? I mean, there's your five senses, there's proprioception, right? And what's the other one?
Vestibular.
Yeah, vestibular.
Yeah.
And maybe we can at some point touch upon those ideas and concepts, because we have people in the audience who are maybe not mental health workers or whatnot. But how did you come across this subject?
Well, a few years ago, I was helping a friend, Brenda Smith Miles. We were revising a book that she wrote, and it was the book that you mentioned in the intro, the Sensory Issues and High Functioning Autism book. And we were revising that to do with the second edition. And her first edition of that book only had 7 senses. And through the revision process and doing the second edition, I had heard about interoception before, and I suggested, like, why don't we add this 8th sense? And at that time, I thought that interoception was just like, I thought it like had to do with toileting. I didn't really know exactly what it was. And so I started researching a lot about the topic through that revision process of the book. And it was like this, like, just an aha moment for me. I was like, oh my goodness, like, interoception is such a big deal. We're not talking about it. Like, is this really influencing my clients' lives? So being a curious person, I ran right to my clients and started asking tons of questions. And what we discovered was that indeed interoception was a big deal for a lot of them. And I mean, the rest is history. Like, it just has completely shaped my path as an occupational therapist in a completely different way.
Were you working primarily with ASD, autism spectrum disorder folks? I suppose more like what we would used to call Asperger's, right? Was that mostly what your population was, working with adolescents and children, or even adults, or was it something else?
So at that time and currently, about 75% of my clients are on the autism spectrum. But then I have another section of clients that have diagnoses like ADHD, or they might have a history of trauma, or something like an anxiety disorder. And I did work with children primarily up until about a few years ago. I had a couple adult clients, which also completely changed my path. Like, I really enjoy working with the adult clients because they teach me a lot that I can take back and help my pediatric clients. So I have both types of clients now.
Well, okay. So, like, speaking of that, like, obviously, I think in when you're working with areas of trauma, right, trauma and dissociation and other things like that, or just adult, I think all adult issues, the first thing you do, majority of us as mental health clinicians, is we do a very lengthy intake looking at developmental history and kind of earmarking where there might have been breaches in attachment, problems with attachment, or God forbid, so to speak, complex trauma issues. But ultimately, there's something in history that just hasn't been worked out properly. How does the problem for a child of, like, say, interoception / alexithymia play out developmentally, and how does it look for an adult?
Yeah, that's a great question, and one that I am really interested in knowing more about, but we just don't have, like, that information yet.
Well, what would your guess be? Like, I mean, what have you seen? Have you worked with an adult client who has an aha moment, and wait a minute, I don't really know what my language skills. I don't know how to describe my emotions. And I'll bet you dollars for donuts, even though I don't eat a lot of donuts these days. I'd rather have the dollars. I'll bet you that most of their prior clinicians and most adults who are in therapy on some level or another, they've never had their clinician ask them or try to get a sense of how they experience or describe their emotions, right? So there's this, it's a cross communications, right? If the therapist doesn't sit and kind of like get a sense of this, because most of us don't know what alexithymia is, and I think that was kind of discovered or described in the literature back in the 70s or 60s.
Yes. I think the 70s.
And it's been understudied. And I think alexithymia and interoception go kind of hand in hand, right? Issues of interoception and alexithymia go hand. Maybe they are. Maybe that's what alexithymia is.
Yeah, some of the emerging literature is saying that alexithymia is actually just the poor interoception, which I think then helps us to figure out how to support alexithymia.
Well, yeah.
Yeah. And I think to your point with my adult clients, a lot of them with interoception challenges, a lot of them have not a lot of faith in the mental health services that we're providing because they have been so misunderstood for so long. And so the work that, or the supports that they've been provided have been a mismatch for where they're at, which goes back to my original point of like, we really need to be better at figuring out someone's experience and asking the right questions.
Well, you're talking about like being really deeply and consciously phenomenological, like entering into the world of the inner world of your patient's mind gracefully, subtly, right, in a nice way, and helping them to change that or shift it just a teensy-weensy bit, right, which is kind of what psychotherapy is, and I think probably most of the healing arts. But let's kind of go back. We like concrete things and explanations. I think the concrete explanation that you've laid out in your books and your webinars and whatnot and your lecturing is a neurological kind of disconnect in the brains of people, and I guess that would be the relay station. What is that called?
The insula?
Yeah. Can you tell us about the insula? Or insulae,
yes.
Yeah.
The insula. The insula is the part of your brain that processes all of the incoming interoception signals from your body. And everyone has two insula. You have a right insula, left insula, located deep within the side parts of your brain, or your temporal lobe if you're a brain geek like me. And so the insula is the main area of your brain that's processing all of this information and using it. Like that's the area of your brain that's essentially encoding these messages into your emotion. So the receptors in the lining of your stomach pulling in information about the condition of your stomach. Like, is it full? Is it empty? Is it growling? Is it nauseous? So forth, sending that information to your brain. Then your brain uses that information to determine what your emotion is. So if the receptors in your stomach are saying, oh, it's growling, it's empty, then your insula uses that information to say, oh, you're hungry, and communicates with other areas of your brain to help take action, to help guide you to do something to self-regulate, which is hopefully to eat. Yeah.
Okay. But also, if you don't know what those things are, or you have a hard time kind of tapping into them, right, and when that manifests is like 3 hours after you're actually hungry and you're not picking up, you're not understanding what those signals are, you might have a dip in blood sugar. And with that dip in blood sugar, you could experience frustration. But it would be even more frustration for that person if they didn't know how to describe that, because they have alexithymia because of this kind of disconnect in those neural pathways, right?
Yeah, absolutely. And it's even more frustrating because they don't know where that feeling is coming from if they're noticing it. So they don't know to like eat to make themselves feel better, right?
Yeah. And what might happen to, let's say, a loved one or a family member if they see this elicitation seemingly out of nowhere with a person who's having this hunger, drop in blood sugar, frustration, anger. What might that look like? How might that be characterized by a loved one or a family member or a friend?
Yeah. Well, I see this happen all the time, especially in my work in the schools, that individual is labeled as challenging. They have disruptive, they have disruptive behavior, right? Yeah. They're oppositional, they're defiant, et cetera. They're just very misunderstood.
Oh, yeah. Oppositional defiant disorder. It's basically blaming the victim usually, right? Yeah. Yes, that's... Yeah.
Someone told me that oppositional defiant disorder, ODD, should stand for O Dig Deeper, which I love that. I really don't like that diagnosis. And I think it's, like you said, like it's actually...
Yeah. Yes, exactly.
A reflection of us needing to be better.
It's how do we bill for this? How do we make, what did I do on this hour for a psychiatrist or other mental health practitioner, right? And so how do I prescribe for it? Right? There's a whole lot of problems with that, yeah. For those of you in the audience who couldn't see this, I almost spat my coffee out when she called it dig deeper, because that's kind of like what it should be. But okay, so how does that manifest? Say that person stumbles their way through a clunky unreceptive, difficult time within the educational system, and they get out and they might actually get a degree, and they might or not, or they're working somewhere in some kind of a profession. How does that get characterized as an adult with someone who doesn't know they're hungry, gets blood sugar issues, and then doesn't have a way to describe it and gets frustrated and has an outburst? How would that be described as an adult? Just take a guess. I'm kind of playing devil's advocate here, but.
Yeah, well, for some of my clients, then they have a really hard time being functional and independent. They lose their jobs. They continue down this path of being completely misunderstood by people, and they too don't understand themselves. And obviously, as we get older, many of us get more self-reflective. But it's almost a relief to a lot of my clients to learn about interoception, and it gives them this it's a validation to them, oh my goodness, there is a scientific reason why I have felt this way my whole life.
I'm going to take a gander here as someone who opens up to DSM probably a bit more with adults. I might be wrong. I don't know if you use that thing.
No.
Okay.
Not a lot. I'm very familiar with it, but I am not getting it out on a daily basis and looking through it. No.
Yeah. So I think that a lot of interoception, not to rule out other issues, but I think that what happens over time is if somebody has this interoception issue and through childhood, adolescence, beyond, there's a disconnect with themselves and other people. So they feel like aliens walking around in a world with other people, and that's where masking comes in with ASD, Asperger's type. And then it can also be, if you have an outburst like that, it could be described as bipolar disorder and erroneously prescribe something. A person could get prescribed something that doesn't really help them or do them a service and might have side effects that are debilitating for them. Or it could be looked at as a personality disorder, like borderline personality disorder, right? With someone who's not doing a thorough workup, or just doesn't have the time to because it's in an inpatient setting.
Right.
Or a brief psychotic disorder or something. But the real disservice here is we're not, as a society, taking into consideration neurodiversity, right? Which we are all neurodiverse, right? Your experience in life is different. I don't know what your stomach says to you. You don't know what my stomach says to me. I don't know. I don't have your cultural background, your socioeconomic status. It's just, everyone's, the respect of the individual's phenomenological experience, I think, needs to be cultivated more, right?
Mm-hmm. Yeah. I completely agree.
So that's what I think is going on with a lot of people. And you can tell I'm kind of excited having discovered this idea as well. And also thankful that people like you are out there doing more in the field. And I think on the kind of the cutting edge of the helping professions to help other helpers understand this and work with this. Whether you're working primarily with autism spectrum folks, or if you're a generalist like myself, I think that it plays out a lot more. I think that it can help out a lot more with other people besides those on the spectrum, as we say. Well. How would this, do you have any clients who aren't on this, what we say on the spectrum, or do you have any clients who might have depression and you're just able to kind of rule out autism and it's more of an interoception issue and work with alexithymia, say?
Yeah. Well, as an occupational therapist, I'm obviously not a not diagnosing is not in my scope.
But you might have a nose for it. Send them off to a psychologist or psychiatrist or social worker or something, right?
Yeah, absolutely.
But do you ever see any cases like that where you could help people? Do you help anybody outside of your general practice, like that 75% or so?
Yeah. And I think it's interesting because the more interoception work we do, and I love that you were talking about this, a lot of times the diagnosis shifts. because we're really getting at the heart of the matter. If interoception is indeed the heart of the matter, no pun intended. I've worked with some individuals that have been diagnosed with, say, something like bipolar or depression, and working through a lot of the interoception or the alexithymia pieces have really helped tremendously. And working alongside with psychologists, the diagnosis sometimes are challenged, right? And they're like, well, let's reconsider this. And it's just because we're really getting to know that individual and where some of the observable behaviors, the symptoms are really stemming from.
Well, yeah, I think that one of the problem with diagnosis is the problem of human perception. So the problem of human perception is that we reify diagnoses into something that stands outside of a cluster of symptoms or concepts or observations about people, right? Just like we reify psychotherapy techniques and we make them something outside of the realm of another school of psychotherapy, right? They're really they're the same thing, just different labels, right? Or you're basically doing the same kind of thing. So we shouldn't get too attached to diagnosis. Yeah, sometimes I would prefer not knowing the diagnoses of some of my clients. I want to know their history, I want to know their experience, but there's been a lot of research that shows that knowing the exact diagnosis, and good luck with DSM-5, because the inter-rater reliability of that thing's worse than DSM-4, where they were trying to work that thing out. There's very little connection between positive outcome in psychotherapy or mental health interventions and diagnosis. It's not like fixing an arm that's broken. I mean, you kind of know what's going to work, right? Mm-hmm. Yeah. So there's that problem. But how do you think that interoception is going to, based on your current work and where you see interoception research and interventions, how do you think that's going to affect the mental health field and the occupational therapy field, the physical therapy, medicine? Mm-hmm. How do you think that might start to affect things? Well, I mean, I have to be hopeful, right? That's my whole mission with all of this work, is that it'll change things for the better. It'll help enhance the supports that we're providing our clients. It'll help people feel better understood, and it'll help them, I think, even better to help them understand themselves. Can be such a gift. It is such a cool experience when I'm working with my older clients to see their reactions when they finally figure out and discover that what interoception is, and that there's a name for this, in that validation process, is just such a incredible experience for them in and of itself, even before we get to the interoception work. So I hope that can be an experience for many people. And I am just really curious, if we start doing interoception-based supports early on, in early intervention, teaching all parents everywhere how to nurture this sense within their children, embedding it in the schools proactively, is that going to be a more proactive, positive mental health approach to our society? Because we know mental health is tragically rampant and growing. So I'm curious, can this be one of those preventative factors? I would think so. And I think that kind of what I was alluding to is that if you're a child growing up and you don't know what you're feeling, and you don't know how to fit into a world where everyone else can easily pinpoint what an emotion is, or if they have an outburst, they can go, "Oh, I'm so angry," and you're you're trying to intuit at an early level where you don't have higher executive functioning and reasoning going on. You're still in that, you're just kind of swimming in your emotions and having more visual cognitive processes, right? Freud would call primary process. That's going to set in years and years and years of layers of this kind of masking, right? And so if you can, for people who are on that, who might just have interoception problems might just, I guess there's probably more of a correlation between that and maybe proprioception and other vestibular kind of issues for high functioning ASD, or what we used to call Asperger's, right? You could probably intervene early on, but the difficulty is these are before they get into the school system or preschool system. So you have to kind of do like a child education, early childhood intervention kind of a model, I think.
Yeah.
Right.
Absolutely. And I mean, I think too, starting with the parents, because, not in all cases, but many parents are, definitely not in tune with their body signals. So then how does that influence their attachment and attunement process with their child, their infant? And we know that interoception is present at birth, like that most infants are born into the world and they are wired to notice discomfort within their bodies and they cry. And then hopefully that caregiver is attending to the child. And through that dynamic relationship, the child is learning such valuable information about their body signals and their inner world. And so, how do we support parents in nurturing that process?
Well,
right.
Yeah, I think that one of my mentors and a person who I've been kind of studying under with attachment disorder work, Dan Brown, who's up in Massachusetts at Harvard, he says that there's too much attention played on how to the activities of parenting rather than the joy of parenting, which I think is curiosity is like one of the main elements. And I think that's true. So how do you help parents overall? I mean, not everybody's going to buy into this because that's just the way things go, but that you can have some effect on society as a whole and the area you're working in. I think, on having to cultivate that curiosity about themselves, curiosity about how other people work, right? And being curious about how their kids are and taking joy in how they learn and perceive things differently.
Yeah, I completely agree with that 100%.
Yeah.
And I love that shift towards more parenting with joy instead of parenting trying to, I don't know what we're trying to achieve. Like the more activities we do, the better. I don't know what that is. Like we're not really taking time to just most of us be mindfully present with our child and to really connect and be curious about their experience and nurturing that in themselves. So I am completely on board with that. I like that concept a lot.
Yeah, I think that curiosity is the first step in nurturing that, right?
Yeah.
But that's more of what we have to kind of do. And hopefully we don't get burnt out as well as clinicians, and we can still be intrigued and curious and want to help people and by teaching them that they're okay and they on some level, and that their experience of the world isn't wrong. It's just maybe some room for growth. Well, we talked a little bit earlier before we started rolling the recording here about polyvagal theory, and I know that you know something about that. Do you incorporate that into your work on interoception, or have you been looking into it? I'm just curious, because polyvagal theory seems to be another way of looking at the nervous system that is kind of in tandem with what's happening with interoception, kind of busting out and showing up in trauma work and other ways of working psychotherapeutically with people, and probably in occupational and physical therapy as well. So what's your take on that?
Yeah, so I am a humongous fan of Dr. Porges and his work on the polyvagal theory. And this is something if I could pick, he's probably in my top 5 people that I would love to have dinner with and pick his brain, because I have been really trying to figure out exactly how interoception and the polyvagal theory fit together. I have my own theories, but I'm sure he might have different opinions. I'm not sure. But what we do know is that 80% of our interoceptive signals come from the vagus nerve. They travel up the vagus nerve to the brain. So there's a neurological connection for sure there, just through the vagus nerve, right?
Yeah.
And I just am such a fan of his his work on just, the importance of felt safety in our clients and how we really can't proceed before they're feeling safe. And I just think that more people need to know that message. And before we do any of our interoception work with clients, number one is that relationship and the felt safety. You have to feel safe in order to be willing, for a lot of clients, they have to feel safe to be willing to go into their inner experience and to be curious and discover that process for themselves.
Yeah. Okay. So maybe you can kind of like give an overview of polyvagal theory just in general for those people who haven't really been in contact with these concepts, which could be a lot of people out there.
Yeah, I mean, I don't know if I can do that justice because I am not a polyvagal theory expert. I have taken a 2-day course from Stephen Porges, but that's like,
but you're so excited about it and impassioned that I'm sure the way you describe it will be light years ahead of me in my dry technical terms. So go ahead. And you're also the guest, so I'm putting you on the hot seat.
Well, thank you. So I'm not going to even attempt to explain the whole neurology behind the polyvagal theory. And I know it's just big on the vagal nerve and how the vagal nerve like innervates a lot of our facial expressions and our voice. And it's pulling in all of this also interoception information and helping it reach the brain. And so in a nutshell, what I love the intervention piece of the polyvagal theory is that it is our number one responsibility as a therapist or a practitioner is to help our clients feel safe with us. And that's the crux of everything that we do with that client. And I think that a lot of people fall short with being able to do that, I think it's because for some therapists that I have consulted with, they just feel this like pressure that they have to like be working on the goals and making progress. But you can't really get to those places if you don't start with the relationship and the safety piece first.
I would agree with that, but I think you always have to there's always going to be ruptures in our work, especially in psychotherapy. And those ruptures are where you kind of you would bring in something as a psychoeducational piece to provide some insight, some aha moment. Like we went from the upper vagus nerve and facial muscles, right, to more of a fight or flight, which would be the sympathetic nervous system, which is dorsal, right? Or down to, if your client dissociates because of what you're doing, down to more a dorsal ventral or older biological functioning of just checking out. Like I'm paramecium being eaten by some other critter, and so I don't have a complex facial structure and societal kind of interaction with things. I just check out, right? Play possum, so to speak, right?
That freeze response,
right.
Yeah.
So showing that, I mean, this is where the idea of the therapeutic alliance comes in, I think, in medicine or any other kind of like therapy, right? So this is you're absolutely right. And here's the rub. I think if you can't tell what your emotions you're feeling, but you feel unsettled sitting with someone at some point because you're working on something difficult, that's problematic. Or if you come in, you don't know what your emotions are, you have problems with interoception, and you're like, when is this going to end? When am I going to get to the conclusion of this? When are you going to fix me? So a lot of times in therapy, because it is more of this relational repair, attachment repair thing, whether or not you believe that model or adhere exclusively to it, you're kind of fixing things along the way where a person kind of let something go, or the parents didn't provide nurturing early childhood or wherever. Your patients can sometimes drive you or try to drive you to fix them and get impatient, right? And so that's why a lot of therapists will go, oh, well, here's another CBT worksheet, or here's, well, I've got to fix this problem. I'm problem solving, right? Which it gives you a lot of anxiety as a therapist, or it can, to kind of move you away from a metacognition, right, or a mentalizing of what's going on in the session, And so I think that's why you're hearing this from some people. Yeah.
And I have to say I'm guilty of that feeling sometimes too. Like I want my clients to make fast progress because sometimes I feel like that's a reflection on me and my ability to be a great therapist, right? So I completely understand that. And it is so hard, I think, to sometimes be more patient in that process.
And so like the polyvagal theory, it kind of is, it seems like it's a parallel kind of neuroscience concept to interoception. Yes, and Stephen Porges talks about the whole concept of neuroception and it's almost like this automatic process that's happening within our nervous system that helps us to detect danger. And for a lot of people, like with a history of trauma, they might be over detecting danger in their environment because they have learned that their environments are very unsafe. So their fight or flight or freeze system is, always absolutely. On
alert.
Right. And so this is why how it manifests later on for people or even in adolescence or early childhood as oppositional defiant disorder or some other kind of, somebody pegs them with a diagnostic criteria that really isn't the heart of the matter. Well, I think that what we're seeing, I kind of want to wrap up here because we do have to wrap up here, although I want to invite you back on. If anything comes up, you're welcome to come back and talk more about this. I think what's happening in psychology and in mental health and occupational physical therapy is we're seeing more of this kind of, we're moving back to how developmental issues encode and kind of work their way into our neurology, or because of our initial neurology we're born with, right? And I think that we're kind of moving back to more of a developmental model and looking at that, and which is exciting because now we can kind of pinpoint where these problems, like a problem in the insulae or, a problem with vagus nervous system, right? And there are more options out there, and I think we'll see more like cross-pollination or interworking and hopefully less specialization and more integration with other modalities to help people. Yes. Yeah. Absolutely. I am hopeful that all of this work will just be another great addition to hopefully our journey in becoming a healthier and a healthier society from both, our emotional well-being as well as our physical health. And I think that interoception has a lot of potential there for sure. Absolutely. Yeah. Well, starting at a young age. Is there anything coming up, any webinars or trainings or something you'd like to let people know about, or ways people can contact you, Kelly? Yeah, well, they can feel free to check out my website. It's kelly-mahler.com. And we have tons of free resources on there, lots of videos, articles. We have free printables. And then we also have some paid resources on there. So there is a 4-hour online course. So if you are interested in learning more about this topic, that's a great place to start. And can other OTRs or psychologists, psychiatrists contact you for consultation? Yeah, absolutely. You can do that through my website as well. There's a contact Kelly button there, and you can definitely reach out. We hear from so many people every single day with lots of different professional backgrounds, and I think that's what makes interoception one of the exciting pieces of it, is that it's bringing all of our professional minds together and all of our professional interests, because we each interoception influences each of our professions in such a unique way, and it brings us together and working on the common goal. Yeah, absolutely. Yeah. Okay. Well, Kelly Mahler, thank you so much. It's been an honor and a pleasure. I hope you come back. Yeah, my pleasure. Thank you. Thank you for listening. Please take a moment to subscribe to us at Spreaker, Apple Podcasts, or whichever streaming service you use. All material is copyright the Psychology Talk podcast. This show is for entertainment and informative purposes only. If you need a mental health professional, please seek one out. Music is provided by the band Serenati.